everybody, and
just
I'm
to,
sorry that
I don't know
I've
if
had
you
some
guys
IT
hear,
issues,
but she is having some
so
issues,
I think
but
you
she
should
will now
see,
present, but she won't be able to see
you
you or hear you.
afterwards. My name's Farah. I'm a cardiac surgeon, and also I'm really privileged to be the chair of the Women in Surgery group at the Royal College of Surgeons of England. Now, some of you may know that WIN started as Women in Surgical Training in 1991, so almost 30 years ago, and then it evolved into WINS because, of course, surgeons need support throughout their career. So what was happening in 1991? Well, at that time, across all the UK, of all consultant surgeons, only 3% were women, and that didn't seem right compared to who was going into medical school and people ending up as surgeons in terms of gender. So WIN's mission statement is to encourage, enable and inspire women to fulfil their surgical potential. So what's the big deal? Why do we need it? Well, I showed you the headline figure of 3%, but this is data based on 2018, and it's actually in English data, not UK data. And you can see that doesn't project you start off at the left with over 50% of people going into medical school being of the female gender. Not much of foundation years. By core surgical of the people in training are women, and then it drops off at specialty registrar till the time you're left with consultants, and at that stage in 2018 it was 12%. So why the attrition? What's going on? Well, is it stereotyping? Is it what we perceive as the typical surgeon? Is it a perception of surgery not being a particularly favourable specialty to choose if you're a woman? Is it lack of support, lack of role models? Is it something else that we need to be looking into? Women in Surgery does as a group, it's 4 main areas. Collaborate with the Specialty Association. So we're trying to actually encourage changes in practice and behaviour. Sorry about the extra S. We also represent women and the network and try and portray positive images of women surgeons, including social media campaigns. We have a network of over 6,000 people. We try to offer practical advice, guidance, and also support and regular communication. And of course, we're known for both our annual conference, but we spend a lot of time visiting medical schools. I think today there's something in East Anglia, a couple of months. I'm speaking at this Sheffield event, and so we really like to showcase role models for people. So as I said, WINS is free to join. We have over 6,000 members. You just have to go onto the Royal Surgeons of England website, and there's a forum of 14 members who meet regularly, more than twice a year virtually, to deal with planning, writing guidance, etc. And these are the number of ways you can engage with us. So our campaigns, well, not everybody wants to see how wonderful it is and how super everything is. We really encourage, we like to showcase women from all sorts of backgrounds, doing different specialties and sharing their stories. So one of the campaigns we ran a couple of years ago coincided with International Women's Day. And what we thought was we wrote to all our network and we asked them, are you interested in being profiled? And you can see this was just a selection of surgeons who said, we coined the hashtag I'm a surgeon, and for people to fill in the gaps. And you can see, some people, a yogi, a ballet dancer, a kite surfer. And then you can click on the individual profiles. So if you go halfway down, click on Scarlett McNally, you'll find she's also on College Council. She's an orthopaedic surgeon. And you find out all about what she likes to do outside surgery. So we're really trying to say, yes, surgery is fairly all-encompassing, but you are able to have a normal, inverted comma, life outside. And this is just an example of one of our conferences that we ran last year. And the real ethos is of helping each other as you advance. And I'm sorry, this looks a little bit blurry, but we try to have sessions that are tailored to people at all stages of their career. So you can see that in the morning we have sessions for medical students, surgical trainees and senior women. So there's something to support everyone. And this is one of the feedback forms. And the reason I put so much in there is that one of the things that keeps coming up is that it's inspirational and that people really feel lifted after it. And it's the atmosphere. People really appreciate the networking. Our events are very professional, but they're also informal. And people are really giving of their time and want to help other colleagues along their sort of surgical pathway. So how's it going after all that? So after almost 3 decades, well, this year we're up to the heady heights of 13.2% of all consultant surgeons being women. And yes, our graphics have got a bit more diverse. So is that great? You can say that's a 400% increase. Isn't that wonderful? Pat ourselves on the back. Is it really that great when over 50% of women or people entering medical school are women? I'm not sure we've quite got to where we need to be. So on that theme, different specialties have, and this is not to put you off, if you want to do a specialty, you go for it, but you can see that the percentage of women in individual specialties does vary quite a lot. So there is work to do, I think, in some of these specialties. And that leads me to just a couple of slides before I finish. And I used to do a whole series of myth busting. I've had to delete some of these because of IT issues. So lots of myths. And I guess the moral of the story is don't ask people who probably don't have much insight into women and surgery about being a woman in surgery, because many people have trained 30, 40 years ago and things have changed. So a bit of myth busting. Myth 1. Is you can't be a surgeon and get pregnant. Well, here we are. I have it on good authority that yes, you can. And all photographs used with permission, obviously. And this is Mrs. Scarlett McNally, a council member and orthopaedic surgeon in Eastbourne. And as you can see, she's heavily pregnant. She had a number of her children whilst a trainee, and then one, I think, as a consultant. And as she points out, that her tummy was smaller than some of her male colleagues, so it is not insurmountable. Myth 2: you can't be a surgeon and have a family. Actually, you can, because when you get pregnant, you end up with kids and you end up with a family. In fact, these are 2 of Scarlett's children, and she went on to have 4. Obviously, you have to have support either in terms of a partner, nanny, nurseries, whatever, but it is perfectly possible to have a family and be a surgeon. And finally, myth 3: you can't be a surgeon and have a work-life balance. You can. That's me. Even I get some time off. And on the left, you can see me. I was heli hiking on Fox Glacier in South Island in New Zealand, and the one on the bottom right is me attending the closing ceremony, I think, of the Olympic Games. So we do get a bit of downtime in between all the operating. So my take-home message is, can you be a woman and a surgeon? Very emphatically, yes, you can. I hope you enjoy the rest of the session. I will try and join in on the chat. Apologies that I couldn't see you. And keep in touch with us, and the very best of luck. I'm going to sign out now. Thank you. Hi, Scott.
So I've put in the chat that any questions regarding your presentation will be answered in the chat at the side.
Okay. And how do I find that now? Or is it, am I disconnected from them now?
So on the right hand side, can you not see any writing?
Okay.
Can you hear me now?
Yeah.
Yeah. Yeah, I can go next.
Perfect. Thank you.
Should I share my screen? Can you hear me?
Yes, I can.
Can everyone else hear me? I'm not sure.
I think there's a bit of a problem, but yeah, just keep going. We cannot hear you.
Shall I start? Okay.
Yeah.
Great. So hi everyone, my name is Maddie. I'm currently a core surgical trainee 2 at Chelsea and Westminster Hospital. And
No, and frankly, I don't really know.
Can you hear me?
I can, yes. I can also hear Farah.
I'm just going to leave, I think.
Yeah, me too.
Okay.
No
Thank
worries.
I've just muted her. It'll be okay. Can you guys hear me now?
Yeah.
Okay, go for it. Just continue. It's okay.
Sorry, yeah. So my name is Maddie. I'm a core trainee 2 at Chelsea and Westminster Hospital, currently working in trauma and orthopedics. And I'm going to be talking to you today about my experience as a woman in surgery. And then, again, I'll be touching on a few of the misconceptions that I've experienced during my career so far. So just starting off, I think this sort of big thing about being a female in surgery is having role models that are female. And I don't know if any of you have listened to the BBC4 Desert Island Discs recently, but Professor Avril Mansfield, who was the first female professor of surgery in the UK, featured on it recently. And it was a really interesting podcast, and she really touched on how surgery was as a woman back 20-something years ago. And like Professor Bhatti said in her talk, it was a much different experience back then. So my career so far, so I started off at an all-girls school, and I think that was my first taste of realizing that women can achieve any career they want, from seeing my peers go off to university when I was younger. I liked science from an early age, and realized that I wanted to go off to medical school pretty early on in my school career. So I went off to Nottingham University. That's a photo of the first time I ever took a blood test. And when I was there, I didn't know what speciality I wanted to do. I was definitely considering surgery, but I also thought I wanted to be a GP. So I was on the GP Society at university. I also used that time to concentrate on my hobbies, including athletics, and was a treasurer of the society there. And I remember going to a women in surgery conference when I was at medical school, and I think the theme of this talk is really that having role models is so important. So after I graduated medical school, I went off and did my foundation training in Kent, Surrey and Sussex. And I think my first ever foundation job was in general surgery. And it was at that point that I realized, actually, I really like surgery. I really like the fast pace of it. I like the pathologies that we see. And I got to go to theatre quite a lot as an F1. And I got a real taste of what I loved about it. So when I started F2, time came around very quickly to apply for a core surgical training number. And actually, although I pursued a lot of my hobbies at university, I hadn't really appreciated what it meant to have a good portfolio. So I didn't really have a great portfolio. I didn't really know quite what the interview entailed. And it's at this point that I got my first real failure in my career, when I didn't get a surgical training number. And although I was very disappointed and upset to start with, I think it made me really evaluate what I really wanted and what career I wanted. And I decided then that I 100% wanted to be a surgeon, and I was going to make it happen. So in my year of whilst I was trying to get this training number, I went off and did an F3 at King's College Hospital in London. And it was here that I decided I wanted to do trauma and orthopedics. I don't know if any of you ever worked at King's, but it's a major trauma hospital. And I found the trauma calls one of the most exciting things, and I learned a lot. I also found that, so my preconception of going into orthopedics was that it was a real male-dominated speciality. But when I was there, I was lucky enough to be surrounded by a group of really incredible female registrars who really encouraged me to take up the challenge of orthopedics. And then there's a photo of me with some drills doing an external fixation course. Like in the previous talk, you can, even doing surgery, there's plenty of opportunities to pursue hobbies. And I use some of my F3 to go traveling around Central America. Had a great time. This is obviously all pre-COVID. And I also went and got my exam done and got that out of the way. And that kind of leads me on to sort of where I am now. So I'm now a core surgical trainee. I've been at St. Thomas's, and I'm now at Chelsea and Westminster. That I was allowed to do and supervised. And I think that's one of the things I really love about, well, not necessarily instant, but results pretty quickly. Had a slight interruption for COVID. I learned a lot whilst on intensive care, and I think it's important a bit about intensive care medicine. And that's me with two of my other female core surgical trainee colleagues. You do get downtime in surgery, and we do have fun. Just a few reasons why I think surgery is great. A lot of fun. I get to play around with drills and saws all the time. Get to work with other people, and I although I do like my own time, I really like bouncing ideas off colleagues, and it just makes work a bit more enjoyable when you're surrounded by essentially people that you can be friends with. It's practical. I knew very early on that I didn't want to just sit behind a desk all day, and this job definitely isn't that. I'm always learning, always learning. Every day I learn something. I really enjoy anatomy, and seeing that when it's tangible, it makes it even more interesting. It's very diverse. I've met people from all different walks of life, and I think that's one of the reasons why you learn so much, because you work with so many different people, and every day is different. Now, although I've told you all about the positive things of surgery, there are still some myths and some preconceptions, and I think some of them still do exist, unfortunately, but everything is improving. But I unfortunately have experienced a few things, but they haven't deterred me from pursuing this career. So I'll go through a couple of them. So women aren't strong enough. I think into lots of female orthopods, it's all about skill and technique over strength, especially when things
So sorry, I can't see
ankles
your screen
and
anymore.
reducing dislocated shoulders.
Your screen again. Sorry.
Yeah, I don't know what's happened.
Yes, perfect. We can see everything. Yeah. Thank you.
Can you? Yeah. It's male-dominated, male bias, an old boys club. That's what I was quite scared of. But I think although there was an element of that, it's definitely changing. And boys can actually be fun to work with. And the way that national selection works these days is that the old boys club it's much harder for that to continue. Discrimination of females in the workplace from other staff. This unfortunately is still present. A recent study showed 59% of female surgeons have experienced discrimination based on their gender. But like I said, I think this is on the decline. Like Professor Bhatti said, lots of people assume that you can't have a work-life balance, you can't have a family. Or got a family. I know lots of people who do, and working less than full time is definitely becoming something that is becoming more available now, especially with paternity leave, and there's HEE have a return to work scheme for people returning to work after taking leave, for example, from maternity leave. And the Joint Committee on Surgical Training is aware that there are barriers to take for surgeons taking less than full-time training, and they are currently trying to address them. Public perception. Unfortunately, there doesn't go really a week when I introduce myself as the doctor or the surgeon to a patient, and yet within a couple of minutes they are referring to me as the nurse, which, you know, nurses do great. Their job is very different to ours, but people just assume because I am a woman that I am the nurse. Bullying, sexual harassment, and inappropriate comments. Again, this isn't completely wiped out, but it's being called out a lot more these days, and hopefully, you know, it's not going to be too much of a problem in the future. But I think it's being acknowledged that this still exist, and it's an issue still. And then finally, unconscious bias, and that people assume to be a female surgeon you have to be ruthless or bossy, and that really just is not the case in my experience. Occasionally, people will document myself as a doctor when I am a miss, but I don't find that much of an issue. But there is still some unconscious bias going on in the workplace. And then finally, finishing off, the present and the future. I think the most important thing is slow. There's a lot of women in surgical leadership positions, and I think having those women as role models is so important. And like the Royal College have as their motto, #LiftAsYouClimb, I think is taking women with you as you climb the surgery. And I think if you can join the Women in Surgery societies, like the Royal College one, but there's lots in different surgical specialities. There you can meet like-minded women and want to ask questions after the final. Thank you very much.
Hi, thank you, Dr. Garner. That was incredible. So we can do the question and answer at the end, and then we can do it like a panel session, and then both of you can have a go at answering. So should we move on to our next lovely speaker, Miss Venturini? Do you want to
Yes, I can definitely speak. So I didn't really prepare a PowerPoint because I thought you probably have had a lot of PowerPoints from this time of the day. But so I just thought I'd give you a little chat about what my advice is. And I have to say, a lot of the things that Madeleine said are quite similar. And I think they're really valid across surgical specialties too. So just to introduce myself, I'm Sara. I'm a neurosurgery trainee. I'm currently working in Cambridge. And to give you a little bit of background, I'm Italian originally, so my schooling experience was a little bit different, I think, to maybe is the one that you are having. And I moved to the UK for medical school. Italy doesn't have a male or female sort of school system, so all schools is mixed, and you just like go to school with males and females alike. So I never really experienced sort of segregated groups in educations, and I went to a really scientific type of school where, looking back, I was in the minority. About 2/3 of my class were male students and 1/3 of us were female students. But I think because I had very supportive teachers from early on, I just didn't really, I thought that was kind of normal in a way, and I didn't really think about my friends as being male or female. So I guess that's the first thing to say. And then I went to medical school, and when I was back in school, I really liked neuroscience, I liked the brain, and I thought I might want to end up doing something related to the brain later on in my career. I wasn't sure if it was going to be medical or surgical at that stage, but I went to medical school and I moved to the UK and I moved to Leicester where I studied medicine. And I was very, very lucky in my medical school to have some good mentors from early on. And my mentors that supported me the most were mentors in surgical specialties. And I realized that I liked all the things that Madeleine said as well. So the things about the practicality of surgical specialties, how it's quite active and you can use instruments and use your hands, and it's quite creative as well. And so I decided that I wanted to pursue a surgical career. And I had mentors to support me through that. Some were men and some were women. And I think the thing to say, which is one of my big pieces of advice, is mentors are really important, and finding people that support you in pursuing your aims and ambitions is one of the most important things you can do. And if you find good mentors, keep hold of them. Don't let them slip away, and move on, because you want to have those people throughout your education that you can go back to whenever you struggle, so that they can give you advice, and especially if they know you see you progress. And the first mentors I had were actually men. One was a surgical trainee at the time who was really supportive and didn't really think about me in the sense, oh, I was a woman and I shouldn't belong in the surgical field. And another one was a consultant surgeon in one of my early medical school clinical placements, who again was a male orthopedic surgeon, but again was really encouraging and supporting me through clinical times, but also involved in research. And so I think that's something really important to say. That's my big piece of advice. Don't let find good mentors that you can trust. Keep them and keep in touch with them along your journey. The other thing that happened in medical school, I did an integrated degree and I joined the field of medical physics, which again, I would say is probably another area which is fairly male dominated, I would say. But I was very lucky and I joined a whole female medical physics team where I met incredible people. My supervisor was a medical physicist and she taught me about proper science and programming and all the things that I didn't know what to do. And that was really encouraging in the sense that I was able to work firsthand with somebody who was really successful in their field. And, she was another really good mentor of mine that I've kept over the years. I set on neurosurgery as a career to pursue. And then after medical school, I moved on to Scotland for my foundation years. So quite a distance. And again, over there, I worked in various departments, including surgical ones, and that confirmed what I wanted to do. And again, over there, I was lucky that I found one of the consultant neurosurgeons who was another good mentor of mine, who again supported me. And then I was also working with a female neurosurgery trainee in my department. And that was really another really good element to have, to see somebody that you can see yourself becoming in a few years' time. I think it's very important to have people that you can that in a way look like you, more than, for example, a trainee of a different gender might do. And then following my foundation years, I applied for neurosurgery training, and I was lucky enough to get in. And so now I've started my training. I'm in my in Cambridge, as I said. I'm an academic trainee, so I combine my time between clinical work, and I have some protected time to do research. And again, in my department, like you've seen in the slides from Professor Farah at the beginning, I think neurosurgery and orthopedics are the two specialties that are still kind of the lowest numbers of female trainees, but you've got two of us here today, so things are changing. And in my department, I work mainly with boys and men, and I would say that doesn't really, sometimes it might be nice to have some more female colleagues with you, but again, things are changing, and you have to pick your colleagues, and you get on with your colleagues really well, even if they are different to you. And I really enjoy going to work. And I would say that I'm quite lucky in my department at the moment. Everyone is quite supportive, and all the things about discrimination are not really happening, although they do exist. And what I found during my time, and especially before I started surgical training, was a lot of the comments that Madeleine and Farah also mentioned already about, women can't do surgery, you're not strong enough, and all these things that people might say. And I have had those comments said to me, especially from people outside of the surgical field. And you have to, in a way, not let those things put you off. And as I say, find mentors that support you and balance all those negative comments out. And I do think that those are becoming less and less common. And I think events like this and initiatives like Women in Surgery are very good at trying to address those biases and address those myths that are not really true. But I can't say for sure that, they've all disappeared. And I think we all need to work together to make sure that we provide the facts and, find a way to respond to these things with evidence, showing that we can do the same as our male colleagues can do. So I thought I wouldn't add any more just now, because I'm sure that lots of you will have questions about various things. And I would just leave with a couple of pieces of advice that I think would be helpful for everyone, from students at school to medical students at any stage. So the first thing is, whatever your goals are, they are valid. It's not that because you're a woman, your goals should be less valid than a male's ones. So if you want to pursue a career in something that's seen as a male-dominated field, that's okay. You're allowed to have your goals and you're allowed to work towards them. Second thing is, you need to find people that support you, because those are really important, especially at times when things might be hard, and lots of competitive things and difficult things in life are hard at times. And so that's my piece of, if you find good mentors, keep them close. And I think those are the main two things, and I'll leave it as here, and we'll take some questions.
So much, both of you. I think it was very, very inspiring. Prof. Farah as well. They were all very inspiring, and I think it's really important to see representation, especially for the next batch of aspiring surgeons as well. To see that there are women in competitive fields such as neurosurgery, trauma and orthopedics, and cardiothoracic surgery. And I think you've raised some excellent points as well. So thank you so much. So to move on, so the next talk is at 3:40, I think. So we've got around 20 minutes. So should we make this sort of like panel discussion, and then I can pick out some questions from the chat and you guys can answer? Is that okay with you two?
Sounds great, yeah.
Okay, perfect. So, so how do you respond to sexism in the workplace, from Amar?
I think it's a really tricky one, actually, because I haven't really experienced that much of it, but it depends who it's from. Sometimes, I'm not saying, I don't want to encourage it. Sometimes if it's someone that you're directly working with, it can be very challenging to try and sort of raise it as an issue, because you obviously have to work with these people, and you don't want to cause problems. But I think the earlier that you, in any sort of discrimination, it either find someone that you trust, especially someone that you trust is who's more senior than you, and raise it, or raise it straight away and just say something like, it depends what it is. But I think calling it out is important. because otherwise it can carry on. But I've been in a situation myself when I didn't call it out because I didn't feel comfortable enough to do it. So it's a really tricky one, but luckily I haven't really experienced it much.
I have to say I've been quite lucky in the similar sense that I haven't had many experiences of people saying anything really sexist to me. I know that other colleagues have been less lucky, but I personally can't, I've been quite lucky, but I would agree. I think it's very situational. I think it depends on where it comes from. Sometimes people may say something that's actually sexist without knowing or meaning. Especially, for example, you might have a sexist comment being made by an elderly patient, for example, but it's not, sometimes you have to assess the intention, and sometimes it might just be something that they didn't mean as a negative thing. And I think in those senses, I'm more inclined to sort of let it slide. But I think if it's something that's said directly to you, especially with people that you work with, I would agree to try and raise it. Sometimes it's difficult, especially if it's in a group situation. For example, it might be said and there's a whole room full of people, and maybe it might be a case of trying to, address it later on one-to-one. But I would agree. I think it depends a lot on the situation and also on what has been said. If it's something that's overtly offensive and, quite aggressive, I would be much more inclined to address it there and then. It is difficult though if it's from people that are maybe more senior to you, and you don't want to create disruption or have things affect your work. So again, I would go back to the point of having somebody that you can trust and can discuss it with and find a solution on the plan.
That's perfect. Those are great pieces of advice. Thank you. So you mentioned about mentors as well. So could you touch up a little bit on how people can go about finding mentors and finding people to stay in contact with and looking up to, and who do you go to find, sort of?
Yeah, I can go first this time if you want. I think mentors is something that it's one of those things that sometimes the harder you look, the harder they are to find. There is a bit of serendipity that comes in finding mentors, I think. But at the same time, you should try. So if you're trying to look for mentors, people that are, depending on what your stage you're at, obviously that's an important thing to say. So I would always try to advise and try to look for people that are, a stage or a couple of stages ahead of you, in the sense that you want people that can give you some advice. But it's also sometimes nice to have people that are not too different from you in terms of age groups. For example, it's good to have, as a medical student, a doctor that's in training who's a mentor of yours, because they remember going through the process more recently. Similarly, if you have mentors that are more seniors, like consultants and people that have been established in their field, that can be very inspiring because those are people you look up to. You can see a whole career that they've had and they've progressed. So I think there's value in having both type of mentors. In terms of where to look for them and who they could be people you work with on clinical placement. So if you're a medical student, in your own placements, you will find mentors that are consultants or trainees in the specialties you might be involved in. Academically as well, so if you're interested in research and or if you do intercalated degrees in medical school, those supervisors and figures that you have, that people that are mentoring you and supervising you academically can also become mentors that you stay in touch with long term. I think whatever the mentors that you find are, the important thing is that mentorship is a two-way commitment. You can't just expect your mentor to give you advice for nothing in return. So at the same time, to keep, it's important to keep in touch with them and, make sure that you show your gratitude to their advice and mentorship. I think it's a two-way street. They have to also know that they're appreciated as somebody that gives you advice.
Yeah, I mean, I echo all those points. For me, my mentors are people that are just a couple of stages ahead of me, and it's more people that kind of I've got along well with at work. They're on the similar career paths to that I want to go on, and just give me some great advice. I'm also I'm involved in some, although my mentors, it sounds like Sara's mentors just came along naturally. I know lots of universities have mentor schemes where if you are interested in surgery, not necessarily as a woman, but anyone, they can link you up with a doctor who is in that field that you're interested in. And I have a couple of mentees that way. But I think it's good to have it both ways, because if it's natural, then it's easier for you to have a relationship with that person. If it's set up, although sometimes you find someone who is in that career, you may not link as well. But there's both ways are equally as good.
Perfect. Thank you very much. So, so the next question, you both very eloquently put that you guys can have a work-life balance, and surgeons can do that, and you can have a family, and you can, have fun as well, along with work. So, do you have any tips and strategies on how you can manage that and how you can maintain that work-life balance?
Yeah, I mean, I think, although we both said it, I don't know about you, Sarah, but it can be a challenge. It's not the easiest thing in the world, and I think there are definitely medical careers and healthcare careers where it's probably easier to have a work-life balance. I think being good timekeeping is important, and also I think reflecting and knowing what is important to you and doing things that actually that you enjoy and you like, rather than doing things for the sake of it, is important. I think also it also depends on what surgical career you want, and as you have to try. Although surgical training is long, you're going to be a consultant for longer, and actually trying to look ahead and trying to look ahead and think, actually, do I want to have that work-life balance of the consultant is different, but it's definitely doable. And I think it keeps you sane as well, having a work-life balance, because otherwise the work can take over and you'll get really stressed. So having great friends, great family, I think, it's really important, but you do have to make I think you do have to make a few sacrifices, but you have to decide what you don't want to sacrifice and not let that happen.
I completely agree. I think I don't have a lot to add to that. I think I agree with all of it. It is, although we, manage, it is difficult. It's not something that's, you don't have all the time in the world, and you have to, set boundaries and set times, and set yourself goals of, when you're going to be working and when your time off is. I think one of the things I found helpful, and it was almost in a way forced by my location. I moved away from my foundation years from where I studied, and a lot of my friends stayed in medical school. So that made me very aware that if I wanted to see my friends from school and uni, I had to travel back to England, and Aberdeen is, for those of you who don't know, is really north in Scotland, and it's a 10-hour drive to where my friends lived. So I'd have to fly, which means I would have to plan a weekend ahead, and I think that really taught me that you need to prioritize making time for your friends and making time for people that you care about. And I think what works well, especially when you're working, is having some weekends or small amount of time blocked off, where you do no work at all, and you kind of use them as time to recharge and create that balance. I think on a day-to-day though, it comes back to time management and being efficient with your time, and also enjoying what you do, because I think a lot of the things I do around my work. So I work in my, clinical day, but then sometimes I have papers to read and students to teach and talks to attend. I think those things I really enjoy. And so even though technically they are work, there's a gray area in which I think is between the work and the enjoyment outside of work, which I think you need to find. And I think, if you like what you do and you find a specialty that you really enjoy, I think a lot of things around it become, work, but maybe a little bit less than full work.
That's brilliant. Yeah, so your work is your passion at the end of the day, which is great.
I think can I just also add, it's also important to have some time just for yourself as well, because otherwise you end up juggling your social life and your family life as a bit of another tick box thing to have, one of those other jobs that you need to fulfill. And if you don't make sure that you've got some me time, then everything else becomes a chore as well. So you just got to balance all those things, and it's definitely doable, and you just have to be aware of it and not get overwhelmed by each aspect of your life.
That really leads on really well to one of the questions that I was going to ask from here. So this is more related to sort of mental health and how you manage your well-being, and if you're stressed on, like really stressful days, you deal with, deaths or things that you didn't really want to, or complications like that. How do you manage your emotions, and how do you manage that side of things?
I think that's a really good question, actually, for whoever asked it, and it's something that's really, especially now, it's very, very relevant. Whatever work you end up doing in medicine, there will be days that are hard and days when you lose patients, or you have to give bad news to patients' families, or you just had a bad day because of another reason. Your work environment. So all those things do happen, and I would be lying if I said they never happen. And they can be quite tough, especially when you need to go back to work the next day, and you have to go back to work for the next few days because you're working the whole week. And so I think there's a few ways for me, and this is different for every person, I think. For me personally, there's a few things I do in terms of checking in with myself and making sure that I'm not burning out. First of all, I like to, I have a few close friends that I studied with at uni, and we're very lucky to have a relationship where we can just call each other. We've had a bad day and kind of debrief on what went on. And I think for me, that's one of the best things I have in terms of support network. And even though now we all work in different specialties, we are all working in medicine, and we really understand each other's struggles quite well. And so I think having people that you can talk to about those struggles and about those difficulties is a big way that can help you to, reflect on them, find any issues if there are any, and kind of debrief. And I don't think it's a very good idea to keep them all to yourself and bottle all of it up, because I don't think that's really sustainable. And the other thing I do that, kind of going back to what Madeleine said before, I think once you've had for example, a very stressful or busy week, I find that finding some time for myself where I'm not really having to interact with people and interact with, even if they're friends, but interact in a very active way is really important. So doing something, I like running, so I normally go for a long run, and that's a good way I have to kind of, be by myself and kind of de-stress and forget about all the other stressful things that are around me. So those are the two main things I do.
Yeah, I mean, I'm really quite similar, actually. I think having a couple of good friends who you can not, but at least, be able to discuss things that have happened with your day at work with, and for them to actually be able to understand is really useful. I think I also enjoy running and going running, and I think checking yourself and just looking back at I think it's also, I don't know how you guys find it, but I think sometimes, especially if we're working really long hours, you can get into a habit of not eating well, drinking too much coffee, etc., and not exercising enough. And I think just looking at that, and if you eat well and try and get some exercise in, that it's not going to solve everything, but it can definitely help. Just sometimes just having a bath or like watching some rubbish TV is great as well.
You don't have to like running to be a surgeon. You can like other things too.
That is good as well.
I was just going to say that. That was great.
Rubbish TV baths
Yes.
as well.
Do you have any particular recommendations for rubbish TV?
Oh, you don't want to know that.
But that's great. Thank you so much. You've both given us some great coping strategies that we can use on those particularly hard days. So the next question it is about a recent trend, or a recent social media trend. So it's on the paper. Do you know the journal, the vascular surgery journal paper, where it was the hashtag #MedBikini backlash, and they were talking about activities of junior surgeons and their social media and so forth. Do you have any thoughts on that at all?
Like thoughts in terms of the...
So the question was, do you have any thoughts on the sexist paper released by the Journal of Vascular Surgery that led to the hashtag #MedBikini backlash?
I'm sure, I think, was the paper retracted eventually? Is that?
Yeah, I think it was.
Yeah, so I think that's my first comment. Sexy things should not be tolerated.
I think they realised pretty quickly that it was a bit of a no-go.
Yeah.
But I think it goes back to kind of what we said before, in the sense of, sexist comments do happen sometimes, but I will try and, address them. In terms of social media things, I mean, I think that goes for everyone. Like, don't put things that are inappropriate on social media, but I don't think that's a women only thing. I think that's just a general life advice thing. Just put things that you'd be happy for everyone to see. Don't know if that was the question though.
Yeah, I mean, you did touch up on it. So yeah, I think that's definitely good. So I think it's just those ground rules for social media, and also I think that paper was released by quite an older generation of surgeons as well. Perhaps there was like generational gaps there as well. There was a couple of questions about your specialities and things like that. I think people kind of want to know, because you're both of really competitive specialities, what did you do to really stand out and go the extra mile to get into those specialities? Do you have any particular advice? I know you kind of touched up on it in your presentation as well, but anything?
Well, like I said, I didn't get a number the first time I applied. I think it's for specific, I don't know what level everyone is at, but for core surgical training, it might all change because of COVID, but previously there was your portfolio and the interview. For the portfolio, it's a matter of ticking the boxes, and they publish exactly what you're being scored on beforehand. And the key is that a lot of those things you can't get last minute. So it takes months to get some of these things, and so you need to be planning for it well in advance and be aware of what they're going to assess, and just make sure that you try and get everything. But that's a caveat to that, is that you don't need to have full marks in your portfolio to still get the top jobs. I certainly didn't. And then with any sort of interview, especially in medicine, I think you need to treat most of the interviews these days like an exam. And a lot, they're generally not just a chat these days. It's more structured, and definitely something that you can revise for and practice interview technique. And I think the key is practice. Find a couple of friends who are all going to be applying for the same thing, and maybe a helpful senior who's been through the process before, and essentially just practice. And I think my sort of take-home point is that you don't have to have, been on an international committee as a medical student and have 10 papers published to still succeed. You don't need to have everything. Don't be put off by that, because it can be quite daunting and quite demoralizing speaking to some people, because there's some brilliant people out there who've got everything, but you don't need to have them.
Yeah, I think I agree with a lot of things that you've said. I think, so I don't know again at what stage people are at. So I applied for neurosurgery, which is slightly different. You don't have to go through core surgical training, so you apply for it straight from F2, or later on if you apply again. But it's kind of you apply earlier on. The nature of it, I think, is quite competitive. And I think if I remember the numbers from last year, there were about 220 people that applied for 26 jobs. So, the numbers are, if you look at them, it is scary, I'm not going to lie. And I think the first thing is, don't be put off by the numbers. It's so easy to say, oh, well, the numbers are too hard, I'll never get in, there's no point trying, and kind of park it as that. I think that's the wrong way of looking at it, because, the numbers are there. Yes, it's true, but lots of things in medicine are competitive. If you look at, if you start looking at all the numbers, you're going to rule out most specialties if you try to just apply for the ones that have a 1-to-1 competition ratio. So that's one thing to say. I think in terms of, making yourself stand out, I think, like Madeleine said, start early. You can't get lots of these things that, for example, if you've been involved in teaching and research and committees and leadership things and have done audits and projects, these things don't come up, and you can't complete them in a couple of months before your application time. So anything that you do from when you're in medical school will count. So whenever you sign up for a project or sign up for a any kind of commitment, do try and see through and try to get evidence for it, because you'll need that evidence later on when you apply, and keep a tab on all the things that you've done, and try and keep a structure. I think that's important. The other thing I would say is do things you enjoy. Yes, it's a way, you need to tick the boxes that they want you to tick, but at the same time, you should enjoy some of those things at least. I think if you start to do all the things preparing to apply for surgery and you find out that actually you hate 95% of them, maybe that's not the career that you really should pursue if you're hating and everything becomes a chore of all the, all the things that you're trying to do to get in. So I think that's a good thing to keep in mind, that, the things that you do as extra, I guess, to build a portfolio and build your CV and try and get in, you should try and enjoy. And the other thing is, I think it's really important is to try and spend time in the specialties that you think you want to go into, to see if it's actually what you want to end up doing later on. One of the main things they want to see is also commitment to the specialties and show that you have an understanding of what it involves. And for the interview side of things, I would agree with 100% with what Madeleine said. It's all about practicing. Neurosurgery interview is about a half a day selection thing. It feels very much like an OSCE for those of you that are in medical school. There are 8 stations, not this year because of COVID, but on a normal year. It feels very much like an OSCE exam, and I think that's the way that you should take it. Prepare as much as you can, and yeah.
That's perfect. I think we're nearly out of time. So thank you so much for coming in today, and also for your presentations and also the questions as well. I'm sorry that we couldn't get to answer all of your questions, but is there any way that they can reach out to you, like Twitter or email? Or?
Yeah, I'm on Twitter. I can put my thing on there.
Yeah, that'll be perfect.
Yeah, as well.
Yeah, I can work out what it is.
So yeah, so just if you could just put that up on the chat.
Yeah, just put it up on the chat.
Right. Yeah, that was very insightful, and I'm really sorry about the tech issues.
Thank you very much for having me.
Thank you.